Welcome everyone to our webinar, and a big welcome to Dr. Carlo Rinaudo, who is very generously giving us a second talk. So this week the talk is around jaw dysfunction, and could that be what is causing the dizziness, tinnitus, headaches and poor balance that you may be experiencing? So just a little bit about Dr. Rinaudo. He is a registered chiropractor, a researcher and an educator. He has over 20 years experience in private practice, and he obtained a clinical postgraduate training in functional neurorehabilitation or functional neurology and sports chiropractic. So I guess most importantly for us, Dr. Rinaudo is a clinical director and founder of a multidisciplined clinic that's based in Sydney, and it focuses on helping people with a large range of really complex neurological conditions. And I think that's where it comes in for us with Meniere, is that it's not always easy to pinpoint how we can best be helped and what some things are some of the things that might help us. So it's really great that we've got people like Dr. Rinaudo, who has a clinic such as this and has all this information for us available. He's also a founder of the Brain Hub Academy, and it's a professional postgraduate teaching platform. So I'd like to just welcome Dr. Carlo Rinaudo to give us his talk on jaw dysfunction.
Thanks, Jenny, and great to be back for a second instalment. I've learnt my lesson from the first webinar that we did a month ago. The content won't be as long, and hopefully give us plenty of time to answer questions. And if any of you were part of Module 1 or Seminar 1 or Webinar 1, and you have some questions that pertain to that, I'm also happy to answer that as well. So this is an interesting topic. It's one that I've seen clinically for many years, and I think any manual practitioner or any vestibular or otological specialist cannot ignore the unique connection between the jaw, the neck, the inner ear, and the head. They're almost like cogs in the gearbox. When one works or turns, it affects the other, and equally, when it doesn't work well, it can affect the other. And I think this talk is very much along the lines of just expanding your thoughts as people that have Meniere's to, are there other options? I'm speaking to a very well-versed group of people that have explored many things, and hopefully I can just maybe encourage you to consider other options or other professionals that may be of assistance to you. And like most things, you'll find some people that will say that this worked to treat for them, and others that they didn't. And I think if the broader you are, the more open your thoughts are in this manner. I'm sure there are valid points that you'll take from this. This talk is not specifically just on Meniere's. I certainly bring to light some of the points that relate to Meniere's disease, but by and large, this is a topic that I think is very valuable for people with any of the dizziness, chronic dizziness, tinnitus related conditions, which obviously Meniere's is one of those. So obviously big thanks to Anne and her team. It's a great, you guys are doing a great job, and you're very fortunate as members and as people who are listening to this to be part of this group. So thank you again, and always thank you for the opportunity to speak. You don't have to ask me twice. I always love talking. A little bit about me. Well, that's been done. Jenny did a great job sort of highlighting that, but that's for your reference. Just I guess a word of warning or a disclaimer here. I always sort of present this when I speak to people of the public. In this case, obviously, I'm not a dentist or an orthodontist, and what I'm discussing here is based on over 22 years of clinical experience, what I've seen in research, and what I see teaching people across the world on similar topics. So I come to you and I share that information. Certainly not gospel. It's certainly not the be and end all, and it's certainly not meant to replace the advice that you would get from a dentist, an orthodontist, or any other practitioner with specialization in this area. But really, I want this talk to be a thought-provoking talk, one that you can go away and go, I didn't think of that. Or, oh, I wonder, actually, that sounds like me. Maybe I'll talk to my dentist about this. Or I already see a chiropractor, a physio, or an osteo. Maybe I'll discuss these things with this person. And I think if you're having that discussion, if this talk enables that thought and maybe discussions amongst yourselves, then I'm very happy with that outcome more than anything else. And it's certainly not meant to be specific advice to you, but rather one that just that you can have an open discussion with your healthcare practitioner. So yeah, I just want to be clear on that. And again, the intention is really so you can appreciate the jaw, otherwise known as the TMJ, and we'll note it as that throughout this talk. And its disorders, namely the TMD. The TMD is temporomandibular dysfunction, and TMJ is temporomandibular joint. And you'll see why we call it that in a moment. And I want you to be aware by the end of this talk, its relevance, significance, and relationship with many symptoms that many of you experience, whether it be tinnitus, whether it be hearing issues, whether it be balance, headaches, dizziness, and any of those, you'll see a strong correlation between the jaw and other areas. Now, I need to be clear and say this. A correlation, a relationship does not necessarily mean causative. Just because two things that happen at the same time, it doesn't mean that that one causes the other. And just need to be clear on that, because some of the evidence that I'm going to show you and some of the things I'm going to talk about, there's been no causal relationship, but certainly an associated relationship. Now, what does that mean to you? It just means that we want our antennas up, that something could be connected, and it's of value to have these things examined. But I don't want to leave you tonight thinking that every case of tinnitus and dizziness relates to the jaw, and you need to have a jaw problem to have these issues. No, but there is a strong correlation between them. So I'm very much, and how I practice for many years and many decades, is very much an holistic, integrated approach, and try not to pigeonhole someone with a way to look or manage conditions, but really consider many things. And Meniere's, like many other conditions, is very multifactorial, many heterogeneous, meaning there are many things that contribute to it. And last talk, we spoke about things like autoimmune conditions. We spoke about things like cervicogenic or neck-related issues. We spoke about the autonomic system or the vagus nerve. These are all things that are very much connected with it. And unless you have the approach of examining, assessing, or at least respecting that, you can overlook many of these potential factors that can make your life far more accessible, comfortable. And I don't think anyone's saying that we can cure Meniere's, but we can certainly make it more comfortable and tolerable. And we spoke also about resilience and adaptability that we should be aiming towards with any care. And if any of these terms sound unfamiliar or not, you weren't part of our last webinar. Anne has, as mentioned, she's got all these recorded on a great website, and I encourage you to look at it, share it with your colleagues, because not just mine, but there are other talks there that you might find valuable. Okay, so what is the TMJ, or the temporomandibular joint? Big words, but all they mean is there's a joint that connects your mandible, which is your jaw, and the temporal bone, which is this bone that sits here. Now, the important thing about the temporal bone, for you who may not know, is that your labyrinth, or your vestibular organ, the organ that we're all cursing at times, sits within your temporal bone. So the connection between your mandible and the temporal bone is called the TMJ, temporomandibular joint. And if it's not obvious to you, it should be that the proximity between your ear canal, or external auditory meatus, and your temporal, in your TMJ, is extraordinarily close. And it's because one of the reasons that we see these symptoms or these correlation between the two areas is due basically, but in part, because of the physical proximity that sits between these two areas. So that's the temporomandibular joint. TMD, or temporomandibular disorders, is a broad term that talks about dysfunction within that joint. And there are many causes to it, and some of these causes can be dental, teeth, gums, which is obviously why a dentist should be part of your care plan when it relates to TMJ. It could be osteoarthritis or wearing out of your jaw. Obviously, it can be an injury, like a concussion, a sporting injury, a fall that puts undue stress on the joint. Those that have teeth grinding, either during the day or at night, otherwise known as bruxism. And we know stress and other conditions can be attributed to that. There are other conditions, there are other inflammatory conditions, some autoimmune conditions. There also can be an injury, head and neck injury, or direct trauma to the jaw. So they're the sort of the main causes of why someone would have TMD. The symptoms can be many and varied. We can have headaches, head strains, we can have pain around the face, the jaw, the neck. We can get obviously difficulty with the jaw from clenching to grinding to popping sound. So when you open and close your mouth, if you hear this clunk, 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 or you hear a shift, or you look out between the top and bottom teeth, you should have these this vertical line between the top two teeth and the bottom two teeth directly in the center. And if you smile and open and close your mouth and you see the jaw deviate from side to side, that could be potentially a sign of TMD. Uncontrolled or discomfort through the cheeks and through the muscles of the jaw, and they include the cheeks and this large muscle that sits up in the temporal area called the temporalis. Obviously, you can get difficulty and discomfort in your teeth, gum issues, and when you close your mouth, you see this sideways movement. You can certainly get some discomfort with the eyes, pain and symptoms underneath and above the eye. I'll get to the ears in a moment. You can certainly get some difficulty with swallowing, chewing, gargling issues. These can all potentially relate to an issue with the TMJ, otherwise known as a TMD, or temporomandibular disorder. Now, more pertinent to our audience tonight is what it can do to the vestibular system, or its relationship with the vestibular system. And we can certainly hear things like noises, fullness in the ear, discomfort, pain, tinnitus, increase and decrease sensitivity to sounds. You can get vertigo or dizziness symptoms, and some skin-related conditions as well. Now, I'm sure many of you say, your hands up at the moment going, no, that sounds like me, that sounds like me. So this is why Anne showed interest in this topic and asked me to offer us some assistance, because I'm sure once we go through this presentation, you'll start looking at the jaw as potentially a site of why you're experiencing some of the symptoms that you are, or at least maybe a tendency to have recurrency in your symptoms, or an increase in symptoms. So, the question then lies is, if we dig a little deeper, particularly those symptoms that relate to the inner ear or the vestibular system, and what is otherwise, was otherwise known as otological symptoms. Most of you have probably seen a neurologist or an ENT. There is a small subspecialty of neurologists called neuro-otologists, and these people work, in particular, they're neurologists that work really with dizziness-based conditions. So the correlation of the symptoms that we tend to see with TMJ as it relates to otological, as mentioned, dizziness, vertigo, tinnitus, ear fullness, and hearing changes. And again, everyone with Meniere is at the moment going, wow, that sounds like me, and it sure can be. Now, in a lot of my talks, I do include reference papers, and you all have these slides. So I'm hoping you don't all scribble all this down or take screenshots. You've got the slides, so don't fear. But I do include some research papers. Now, it's not necessarily for yourselves to go away studying, although you're more than welcome to. I also include this so you can feel comfortable. What I'm saying is peer-reviewed papers. It's evidence-based information. You can share this with your healthcare practitioners to say, hey, I listened to a talk the other night. This is what this guy was talking about. And just to show some credibility in what we're saying, to maybe have a discussion with your healthcare practitioner. But the overlap of otological symptoms with TMJ is remarkably high. To give you an example here, in this paper to the left, they looked at subjects with TMD and they reported earache to be 65%. 60% of patients with TMD had tinnitus. 90% of people with TMD had ear fullness, and 25% were asymptomatic. Of asymptomatic people reported tinnitus. So a large percentage of people with TMJ disorders also suffer from otological symptoms as well. And again, this paper, the highlight here was patients in the TMD group compared to those that didn't have TMD had a high incidence of otological complaints compared to those that didn't. So the prevalence and the correlation is very high, I guess is what I'm trying to show here. And these other studies showed very similar. It was concluded that tinnitus is associated with TMD and altalgia. Altalgia is discomfort that relates to the ear. Dizziness, vertigo, stuffy sensation, hypoacusis, which is low or decreased sense of hearing, and hyperacusis is hypersensitive to sound, as well as high levels of depression. And this paper also went in to discuss, again, that high association between TMD and these other otological symptoms, but also sleep bruxism, which is that night grinding that we spoke about earlier, as well as tinnitus. Again, just a few other papers here. Just you can see some highlights here. The prevalence was very high, 8 times higher. So people with TMD had an 8 times higher prevalence of getting tinnitus compared to people without TMD. And they also showed higher levels of depression and other related symptoms as well. So I guess the point what I'm trying to make here, and it's not what I'm saying, but what the research is saying, is that there is a strong correlation with joint dysfunction and common symptoms that you experience. And they also include depression, poor sleep quality, and related symptoms. There is also, and as a chiropractor and as someone that has seen, it looks at body alignment, neck issues, balance, poor posture. Over the years, I've worked with a number of relatively well-respected, integrated, and holistic dentists. And together we've seen a very strong correlation with dental occlusion. And dental occlusion is just another way to say how the teeth line up, and the relationship that has with how the body lines up. And what we found, not we found, but the research, and I've supported this with what I've seen, is that when you have these different malocclusions, or where the joints, where the lower jaw or the mandible sits with the upper portion, and when there's a class 2 bite where the lower jaw sits further recessed from the upper, and you can see what we call an overbite, more commonly referred to as an overbite, we see this forward shift of weight. When we see an underbite or a class 3 jaw malocclusion, we see someone that has a posterior center of pressure. Now, the importance of this is, and what we find is that the jaw acts like a pendulum. If it is shoved backwards, when we have an overbite, we have a compensatory forward posture of the body. When we see an underbite where the jaw is protruded forward, we see a relative posterior shift of the posture. Now, we may see people that come in with recurrent neck pain and current muscle stiffness, and they're getting a lot of work physically on their back and neck and otherwise. Maybe even coming in with tight Achilles or calf muscles or leg muscles. Understand that may well be because the body is compensating for what is happening at the TMJ or at the jaw. So again, an holistic approach is one that always should be implemented. And if it's not one that your private practitioner or healthcare practitioner has competency in, then hopefully, we're seeding that opportunity to maybe discuss this with other people, or maybe they can refer you to someone who may have a better understanding. But there's a strong correlation with that jaw position and postural orientation as well. And again, don't take my word for it, but there are many studies here that talk about subjects with and without TMD presented with global posture alignment issues. But postural changes were more pronounced in people with TMD. So obviously there are many causes to many things. I'm not for a moment saying that the jaw is the only reason, but one that gets often overlooked. And when you're seeing someone with recurrent spinal or postural or back or muscle tension issues, and then you're not getting the result that they or you would expect, then it could be because of what's happening with the jaw. And again, there's a strong evidence of cranial cervical posture. So basically, the changes that one occurs at the neck and at the head is seen with myogenic or muscle-related TMJ problem. And there's moderate evidence that this distortion is linked with the position of the jaw. And this review of the literature that spoke about TMJ or TMD with postural assessments, it found that there was a correlation between anomalies of the TMJ and dysfunctions of the vertebral spine. And this is what they found here, again, supporting what we found, that when the jaw gets recessed, when you have an overbite, you have this forward posture that compensates for it. When it comes to the neck, what's the correlation between the jaw and neck issues? And again, show some evidence here. There's a strong association that was observed between the presence of TMD and the presence of spinal pain. This association became stronger as the severity of TMD increased. So what it meant was, the worse the TMD, the more chronic the condition, generally the worse the pain relates to the pain was found within the neck. And again, the disability was also shown to be the neck disability, the inability to turn the neck, or comfort levels was also shown in this paper to be high levels of muscle tenderness in the upper trapezius and the temporalis muscles. So basically, they found an association between the muscles of the upper shoulder, namely the upper trapezius, and the muscles of the jaw, as mentioned before, the temporalis. So the temporalis, the jaw muscle, and the upper trap muscle was shown to be highly correlated. When one wasn't working, it affected the other. I remember I gave that analogy of the cogs in a gearbox. When one doesn't work, it will affect the other, and normally in a negative light. Now, there are relatively few papers, unfortunately, that spoke about temporomandibular disorders. In this case, they referred to it as a craniomandibular, which is they're referring to the same thing, and patients with Meniere's. And there weren't many papers that spoke of this, but again, I'll read here. Clinical symptoms of craniomandibular TMD, such as pain in the face or jaw pain on movement of the mandible, fatigue of the jaws, and pain located at the vertex of the head, the neck and the shoulders, and the temples all occurred significantly more in patients with Meniere. So they compared a group of people with Meniere's compared to those that didn't, and they found that Meniere's patients, or patients with Meniere's, had a higher experience of TMD related symptoms. So again, it's not necessarily causative. It doesn't mean that the TMD is causative of Meniere's, and I don't think anyone would be suggesting of that, but there is a strong correlation. And when we're trying to relieve symptoms, improve quality of life, reduce frequencies of attacks, and make your experience in between attacks more comfortable, then I'd be suggesting that we do consider the TMJ as an area of value. So I want to discuss with you, some of you are probably thinking about, well, how is it that the jaw is related to my Meniere's or dizziness symptoms? And that's a great question, one that I want to discuss briefly here. We need to understand when we're looking at, and we showed this slide last time, we've got the peripheral vestibular system is one that relates to the organ of the ear, the labyrinth and the cochlea, and the nerve that connects the ear to the brain. That's referred to as the peripheral vestibular organ. And then we have the central vestibular system, which is really everything to do with the brain. Now, when we talk about the connection between the inner ear and TMJ, we're not really talking about the effect on the peripheral system. We're really talking more about the effect on the central vestibular system. So please be aware of that. So when if you go to your ENT or you go to your neurologist and you said, look, I heard this talk about the jaw being maybe causing my Meniere's, I'm not saying that. All right, because they're immediately going to say, well, that's impossible. There's no direct connection between the inner ear and the jaw. And I do relatively support them on that. But it's the connection between the neurological connection, not the structural connection between the two, that I'm more interested in, and where most people are suggesting the connection. What we need to be aware of is this important nerve called the trigeminal nerve. Last time we spoke about the vagus nerve. Another one that I want to talk about here is the trigeminal nerve. The trigeminal nerve is the nerve that supplies your face. It's the nerve, it has three branches. It has this upper, middle, and lower branch. Don't worry too much about their names. They supply all the sensation of your face. They supply the muscles of chewing and the little muscle in your inner ear that helps dampen noise. All right, so this trigeminal nerve is really important. It's one that, along with your vagus nerve and obviously your vestibular nerve, are ones that I would suggest you become a little bit familiar with. But if not, I'll talk about it this evening. So as mentioned, the trigeminal nerve supplies the face. It has these functions. But what's really important is this nerve takes information and also sends information to the muscles of chewing. It connects to the brain in this area of the brain called the brainstem. Now, stick with me here. You'll see why I'm bringing this up, because if you understand where it sits in the brain, you understand why it's important for people with Meniere's and other dizziness conditions. So the nerves that come out of this part of the brain supply your face, supply your face. And when you feel something in the face, the information travels along these nerves and sits here in this long nucleus or area within the brain that takes this information. Now, again, what does this area have to do with my dizziness? So a couple of things. One, the proximity. We spoke before about the location of the inner ear to the jaw. There are some theories, and these are some of the more, some are more current, some are a little outdated theories as to why we see people with TMD have a lot of these otological symptoms. They do also suspect that it could be due to a nerve signal that occurs. They suspect that it could be because of the mandible, or the condyle, which is this bone here, an inappropriate position within the temporal bone can trigger some ear-related symptoms. And also the muscles of the jaw in itself can also trigger a response back into that brainstem. So just stick with me here. So we spoke about that brainstem, and this is where it sits relative to the brain. So here's your, the big melon mass that sits above. Within it, you've got this very important structure called the brainstem. This brainstem takes all your inner ear, so all your hearing, all your visual, all your vestibular, all your pain processing, your autonomic function, all of it gets processed in this very important area called the brainstem. Now, what's important about this brainstem is they develop embryologically together at the same time as we develop as above. So there's an old term that neurologists or neuroscience, people in neuroscience talk about: neurons that wire together, fire together. And what that means is, if an area of the body develops at the same time, in utero and as we develop in life, that they are connected, not just physically, but they're connected neurologically. Think of it like the wires are joined and they influence each other. So the importance of that is this, that if one area of that part of the brainstem doesn't work particularly well, it will invariably have an effect on its neighbors and cousins. And when we look at the brainstem, we have all these areas that are connected. So this is this area, this green area here is that trigeminal nucleus. We've got the cochlear nucleus, which takes information from your ear. We have the solitary nucleus, which takes information regarding hearing. We've got information from your face, from your vestibular organ, and so on and so on. So I just want to point out that this area is like a big house that in this house you've got all these multiple doors, and all the family members sit within. And invariably, you know that you can't affect one person in the house can't really be so distinct from another. So when one's unwell, think of one family member has got COVID. Even though we can try to isolate it, the reality is that we're going to be affecting other areas. And it's the same here. When this trigeminal nucleus has been affected because of an issue with the jaw, it will affect the cochlear nucleus. It will affect the vestibular nucleus. It will affect your autonomic nucleus. So you'll start to see when one area is affected, when neurons that are wired together fire together, when one area doesn't work well, it will invariably have an effect on another. When we look at this a little closer, this information from our face, the trigeminal information from our face, feeds into that brainstem. Now, that brainstem also takes information from our neck. And what's not shown here, it also takes information from pain modulating areas, from our autonomic centers, so our stress response areas, auditory areas, balance system, our postural system, and our visual processing system. So, and they all merge, all these sensors merge into this area. So when one of these family members are affected, it will invariably affect others. Now, it doesn't always, and there's always variations, but we often see it. And it's this convergence of different inputs that, in my opinion, and what most people are expressing as well, is the reason we see the connection between the jaw, the neck, auditory, vestibular, and other responses. It's this convergence of information that comes into one little pocket or one house, and when one's affected, it tends to affect the others as well. So how do you know if you've got a jaw or a TMD problem? Self-assessment. I mean, most of you guys at this stage are probably thinking, yeah, I think what Carlo said, it sort of rings true. You know, maybe discomfort, aching around the ear, around the face, locking of the jaw, clicking and grating, becomes uncomfortable, or you have an uneven bite, or, you know, one tooth contacts more than another, headaches, earaches, eye pain, and neck and shoulder pain. there's some of the self-assessment things that you could do quite easily now to maybe identify that there could be a problem. The dentist or orthodontist will obviously take that a step further, look for signs of irritation or inflammation. They'll listen, maybe with the stethoscope or some other instrument, listen to clicking. They'll check your range of motion, how little or much your jaw moves sideways or up and down. They'll do what they call an OPG exam, X-ray, and this is what it looks like. And this is, so basically it's the X-ray is placed inside the mouth, and it opens up the jaw. Obviously the jaw sits this way, but what it does, it opens it up in this manner. Or the imaging or the software can do that. And you can see your TMJ, your temporomandibular joint on the left, or that's the right, and there's the left. You can see it, and they can understand where it's sitting, if there's any wear and tear or anything wrong with the jaw itself. And obviously they can rule out dental and gum disease. A functional assessment is one that, in my opinion, looks beyond the jaw and looks at many of these other factors. We, in our office, would do balance testing. We would do a postural assessment. We would test the sensitivity of the trigeminal nerve, and there's many ways in which we can do that. We can test for pain threshold, so how little or much you can take in terms of pressure. We test for light and noise sensitivity. We can certainly look at the neck in terms of its position and alignment, and we can obviously look at the neck functionally from a joint perspective as well. Treatment options are many and varied, and some or many of these may be on offer to you. Obviously, the more traditional medical options include anti-inflammatories, opioids, and pain relievers. If it gets bad enough, there can be antidepressants just to relieve some of the issues. And don't get me wrong, I know I'm talking to a group here that speaks, that understands chronic symptoms, particularly those that are elevated. But a TMJ or a jaw-related problem can be quite distressing to someone. So antidepressants, anti-anxiety medication, and muscle relaxants can often be prescribed. Dentists can use splints or ways that they can correct malocclusion. There may be night plates that we can use to reduce grinding or bite plates. And obviously, orthodontics and braces may be used if applicable. So what are the sort of things, again, from a more functional integrated approach? And this is the way in which we would approach this in our office. And don't get me wrong, if someone needs a pharmaceutical or someone needs a dental option for treatment, then I'm certainly referring them out. But we see a lot of people that come to us from dentists and medical where that standard care hasn't worked, and so they're now looking to us for a more functional approach. We do trigeminal nerve stimulation. We've got these little devices that we place in the skin, and we can stimulate the vagus nerve. Some of you may be familiar with Cephaly. It's a treatment that's used for migraines, and anything to do with trigeminal nerve stimulation has been is very well referenced and evidenced to show and help people with migraines. So we use this device on the left as opposed to the one on the right. The one on the right is available for people to purchase just through websites and so on. No disclosure on that one, but you can look at that yourself. Again, we can use low-level laser therapy or cold lasers. Have a great way to stimulate, again, various parts of the brain. We can stimulate the nerve itself. We can use various TENS machines or neuromuscular therapy. And this is one that some dentists can use as part of their therapy. They use these little pads that are placed on the muscles, and they stimulate the muscles with the intention that it stimulates or sedates that part of the brainstem that I referred to before. Vestibular therapies are at our disposal, and I'm sure many of you are familiar with these, that can use certain eye movements, therapies, some balance retraining. We may be using virtual reality as we use in our office, but there are many tools that I think most of you here would have some exposure to over the years. One that I find works extraordinarily well with TMJ related issues, whether it's an anti-anxiety based approach or whether it's a brain sedating therapy is the vagus nerve. And we can use various vibratory tools. Again, we can use lasers on the carotid where the vagus nerve runs up, or we can use these specific ear clips, attachments that send a very light current through to the only superficial branch of the vagus nerve. And this is one that I hope most of you looked into after we spoke last. It's one that works a treat, and one that you should be considering even for Meniere's. Notwithstanding, obviously, looking at musculoskeletal therapy of the neck, spine, upper back, whether it be chiropractic, physiotherapy, osteopathy, massage therapy, acupuncture. I'm open to many things, and I think many people have tried many options. So find the right person for you that can provide this sort of manual therapy, but with the intent of changing or assisting jaw function. There was a great study that looked at the relief, symptom relief after treatment of temporomandibular and cervical, which is neck, disorders in patients with Meniere's. This is a great study that I wanted to bring to your attention. It's a little bit outdated now. It's about 20 years old, but it was a 3-year follow-up, so it had some weight. And what it looked at is people with Meniere's, they offered treatment to the jaw and the cervical spine or the neck, and they looked at what improvements they saw after 3 years follow-up. And it was a group of 24 patients with Meniere's. And what they found was that a coordinated treatment of the jaw and the neck, so rather than one or the other, both together, in patients with Meniere's is an effective therapy for the symptoms of this disease. So this is Meniere's specific. And what it showed here is at these 6-month intervals, it showed that, so this is a rating score of 10, 10 being extraordinarily symptomatic, 0 being no symptoms. And what they found is over a 1 year, 18 months, 2 years, 2.5, and 3-year period, what they found was that ratings of vertigo, dizziness, tinnitus, fullness, facial pain, pain in the neck and shoulders, and headaches decreased from at least a 5.5 to 9 out of 10 at start to a 0 to a 2 out of 10 over 3 years. Now, I don't know about you, but I'm sure many of you have had this condition for many years, are looking at that going, wow, that's pretty good. I'll take those numbers any day of the week. So again, I just wanted to leave you with this, that there are options with you to consider when managing your Meniere's. And this is a great paper that looked at the combination of TMJ work. And I think from memory, they used a splint with cervicogenic work, which is work on the neck. And that combined work decreased the symptoms of Meniere's by, I think everyone here, a fairly significant amount. And it really you could argue that it kicked into gear. And by 1.5 years, most people got maximum improvement and a small improvement thereafter. So it's a pretty good score. Other improvements can be what we call transcranial direct current, which is a more novel way of stimulating the brain to manage people with dizziness, and one that we use in our office as well. So hopefully we've done well with time. It leaves us time to answer some questions. But if you want to contact me, I'm available at any of these, email, Facebook, Instagram, all sorts of things. But reach out if you have any further questions. And I'll leave it at that and open it to the floor to answer any questions.
Thanks, Jenny. I think you're going to be doing this. Yeah.
Yeah. Oh, can you hear me?
Yes.
Yep.
Yes.
Okay. Thank you very much, Carlo. That was really informative and gives us a lot to think about in terms of what we can do. Other things that we can look at in terms of trying to get some relief.
Yes.
So in terms of the chat, now Lynn has said that a vision session with a specialist could be great. I'm not sure if that might have been in relation to possibly work that you have done with one of the other members in the group who was telling us about it a little bit earlier.
Yeah.
But I guess the question that I had, which I guess you answered early on when you said that there's not necessarily any kind of relationship, but I had wisdom teeth surgery when I was nearly 18, and I woke up during the surgery. I was conscious. I tried to get up off the operating table. And I remember thinking, how does the surgeon fit his whole hand into your mouth? Like it's, I thought, oh, I must have been, not with it. But years later, a theatre nurse said to me, no, they dislocate your jaw. And so my Meniere started when I was 20, which makes that was only a couple of years after I had that incident. So I guess I never ever thought about it in terms of the Menieres, but I guess that is something now that makes me wonder whether something could have been put out of place at that time or gone wrong. But anyway, that was my own experience.
Look, it's one that I think other people might share or have something similar. I can't say that I've come across that cause, but it's certainly a traumatic event to the jaw, even though you weren't conscious. So I guess I would encourage you to maybe speak to someone with specialization in TMD. And I should say to you, just seeing a dentist and orthodontist, particularly at some of the more health fund based centres, they have very little understanding of the TMJ with respect to what we've spoken about. They'll look at the teeth and the gums and they'll do a great job at that. But you do need to find someone that has experience, expertise, and further training in the jaw as it relates to the teeth and the head and so on. So I would encourage you, Jenny, maybe to reach out to look for someone. And if you're unsure, just you can contact me and I can sort of put you in contact with people that we use. But yeah, it might be a value. It's I'd be reluctant to say that there was a causal relationship between the two. I think we just got to be cautious in saying that, but not to say that it couldn't have had an impact.
Yeah. Oh, thank you. Yeah. No, well, that's definitely something that I can follow up and just very interesting. So Lynn has asked, does middle ear infection, otitis media, fit in here?
So otitis media is, as mentioned here, it is it's a middle ear infection. Most of the where the labyrinth is, or the inner portion of the ear, is located in the inner ear. So there is a barrier between the two. So they're not necessarily related. But there is obviously a connection between the middle ear and the eustachian tube. And most of us know that when we have a blocked middle ear, like when we're traveling, what do we tend to do? We tend to chew and open it and close our mouth. So there is a connection between the middle ear and our jaw. And again, it'd be fair to say that if there was a problem with the jaw, then there could well be a blockage of the middle ear. There could be some influence that it's having. Again, it's probably not my area of expertise in that area, but it's probably worth exploring. And if you hit a brick wall from someone who probably doesn't know much about in this, with no disrespect, I think acknowledge that and just probably look for someone that does.
Okay, sounds like a really good idea. Because I'm sure there's quite a few of us who've had that issue before, where we've sort of reached out and then found that we just don't seem to get things answered. Yeah. So Narelle has asked, can chronic, like round the clock ear pressure, be linked to TMD? She says she has no jaw, neck pain, etc., but chronic tinnitus also. both for several years now.
So look, in light of what I've said, you do need to have, there needs to be some criteria that connects the jaw. So with the inner ear and the tinnitus. So if I went through that slide that spoke about some of the subjective or some of the self-rated symptoms that you would have, speak to a dentist about regarding inflammation and some other things that would give you a sense to say that the jaw is affected. Just because, she said here, I have no jaw pain, neck pain, etc. Then I think it'd be fair to say there's probably not going to be too much connection between the areas. But next time she's seeing a dentist, maybe ask. I'll give you a little checklist of things that you could see. If you tick one of those, probably not. If you tick a few of those, then maybe that's worth exploring further.
Okay. Next up is, could whiplash injury and a skeletal back curvature cause Meniere's?
No. So not, okay. Again, I'll be clear in this and say not cause Meniere's. It can be associated, and we saw in that last study where, work, and even as a chiropractor for many years, I know I've helped people with Meniere's symptomatically by doing work on their neck only. So there is a connection, but I've got to be very careful to say that is not a cause. Can whiplash injuries and spinal neck issues contribute or inflame or aggravate Meniere's? I would say yes. Can working on those areas help someone with Meniere symptoms? I showed the study to say yes, and my experience would say yes as well.
Right, okay. So, and then we've got from Lisa, can TMD be linked to vestibular migraine as well?
That is 100%. Now that is one that I feel very confident in saying, yeah, definitely. TMD and migraines, in particular vestibular migraines, which is a variant, because of that connection, that trigeminal, brainstem, neck convergence area and vestibular convergence, we see a strong correlation. So as part of our initial assessments, we always do a TMD check or a TMJ check with people with vestibular migraines. Now, in many people, it's not a problem, and so we don't have to worry about it, but you don't want to overlook it. It's one that can be very influential.
Okay. Well, that's really interesting because some people have MD and vestibular migraine. So that's, I guess, for those people who do have both, that's a very interesting thing that they should maybe think about too.
Yeah, remember, the caveat of this talk was really about thought-provoking. And I just want people to walk away going, and not be a hypochondriac or anything like that. I want you guys to be, okay, is this something I need to consider? Do I tick any of the boxes that are worth exploring? And if I do, let me ask someone and let's see if that can make a difference. I think that's a reasonable, fair expectation from what we're talking about.
Right. I think so. I think we need all the help we can get. And I think that the biggest thing we need to have is an open mind about what we need to look at. Alison says a chiropractor in Newcastle uses a myo munchie for jaw development and jaw training. Any thoughts on that for us?
I've not heard of the myo munchie. I imagine it's maybe a splint. It's a soft splint that they can wear, and that can train the muscles and that jaw. Normally, what they do is they offload or take the pressure off the jaw, and they train the muscles of the jaw to be more stronger and stable. If that's what it is, then yeah, look, I think that they're a low cost, generally good option to start with.
Right. I don't know how we're doing for time, Anne, but
one more.
We've got another one. Matthew says, I have multiple neck and jaw issues that have become more noticeable after many years. Could it be inflammation from MD causing these other issues?
So the person should have multiple neck and jaw issues. that come after Meniere's?
Well, they've become more noticeable after Meniere's.
Yeah.
Could it be inflammation from the Meniere's that's causing those other neck and jaw issues?
So obviously the inflammation that occurs within the cochlea and the labyrinth is quite localized to that area. But if you remember, for those who listened to our last webinar, we spoke about inflammatory and autoimmune conditions as being fairly consistent with Meniere's. So with that, it's, when you have an inflammatory condition or autoimmune, most joints or some joints can be more affected than others. So it's not surprising that the jaw can be inflamed during those periods. Now, again, I probably don't have enough experience or see enough to see that, but I think it makes sense. I think it could, again, when you have your Meniere's episodes, maybe do a little TMJ check some of the open, move the side, palpate around the jaw, and see if they are potentially more affected than when you don't have the episodes. And if that's the case, then that would certainly guide you to say that maybe we've got to explore that a little further.
Okay. Carlo, thank you so much. We won't keep you any longer. And we really appreciate very much the fact that you've given us two really interesting talks and a lot of things to think about, and basically a helping hand, which is wonderful. Thank you.
That's awesome. Thank you so much, guys. So yeah, if you have any questions, reach out, and we'll circulate the notes as they come, as she disseminates them very shortly, and hopefully it becomes online in the next few days, which is great.
Okay. Thank you very much, Carlo. Really.
You're welcome.
Once again.